This is Dr. Timothy Collins. Welcome back to part 3 of our lecture on headache and head pain. In this section, we'll be discussing headache treatment options. In general, narcotics or opioids are inappropriate for the management of chronic headache disorders. There is evidence in the medical literature that other options actually provide better acute relief. Most recently, in 2017, there was a randomized blinded trial showing that the combination of prochlorperazine and diphenhydramine was significantly better than hydromorphone for acute relief of a headache in the emergency room. When treating headache patients, keep in mind the possibility of medication overuse headaches. This is patients that are taking excessive amounts of short-acting analgesics that actually results in a higher headache frequency caused by the medications. This is most often a concern in patients that are taking more than one dose of a short-acting analgesic daily for their headaches, and is more of a problem with butalbital-containing compounds such as the brand names Fioricet and Fiorinol, as well as short-acting opioids. Rebound headaches can also be caused by patients using excessive amounts of caffeine, which we often define as the equivalent of more than 3 cups of coffee a day. Medication overuse headaches does not appear to be a significant problem with longer-acting nonsteroidal anti-inflammatories such as naproxen. Acute therapy of a headache disorder is the use of a medication or treatment that is intended to significantly improve or resolve their current head pain complaint. Acute therapies do not significantly reduce the headache frequency. Prevention or prophylactic treatment of headache disorders are the use of medications to reduce the frequency of the patient's headache attacks. In general, the benchmark used in clinical trials is at least a 50% reduction in their headache frequency. These medications often take weeks or months to be effective, and so a prolonged course of therapy is needed to assess effectiveness. It's often critical with patients to discuss this and set their expectation that this medication is going to take a while to be effective. For acute migraine treatment, there are a number of FDA-indicated medications. The first class we're going to talk about is the triptans. There are 7 medications, as you can see, in this category, and they've been on the market since the 1990s. In general, these medications work for approximately 2/3 of the people we give them to, but all medications are not equally effective. You may find that your patient responds better to one triptan than the other, and it's often helpful to try more than one of the medications from this category. As a group, these medications are contraindicated in patients with a history of ischemic stroke or myocardial infarction, and we tend to avoid them in patients with significant coronary artery disease requiring intervention, even if they've not formally had a myocardial infarction. One thing to note about these medications is that 2 of them, naratriptan and frovatriptan, have a significantly longer half-life than other medications. Frovatriptan in particular is specifically FDA indicated for menstrual migraine. There are several new acute therapy treatments for migraine headache that just received their FDA indication in 2020. The first is Ubrelvy, which is a small CGRP receptor blocker that's taken orally. This medication has very few side effects and is generally very well tolerated. It is, however, metabolized primarily by the CYP3A4 system in the liver, and patients that are taking strong inhibitors of this system, such as the oral antifungals, should avoid the use of this medication. Another new medication recently approved is Rayvow or lasmiditan. This is a receptor agonist for the serotonin 1F receptor. This medication has a different mechanism of action than the triptans and causes significant drowsiness or cognitive impairment for up to 8 hours after it's used. Other than that, it has relatively few side effects. Rayvow is specifically labeled in the package insert that patients should not drive for up to 8 hours after they take this medication. There's a third new medication approved early in 2020 named Nurtec or Rimegepant. This is an orally dissolving tablet that is also a small molecule CGRP blocker. Similar to ubrogepant, this medication has relatively few side effects and is metabolized by the same CYP3A4 enzymes in the liver and should not be given to patients that are taking oral antifungal agents. There are a few other acute therapies that are FDA indicated. There is an intranasal form of dihydroergotamine called Migranol that can be effective for patients who are unable to take an oral medication. DHE is a vasoconstrictor and can have significant side effects if overdosed and is contraindicated in patients who have a history of myocardial infarction or ischemic stroke. Cambia is a powdered form of diclofenac potassium that has a relatively rapid onset compared to other nonsteroidal anti-inflammatories. It is specifically FDA indicated for the treatment of migraine. However, because of its cause, there are insurance limitations placed on it, and patients typically have to have failed 2 or 3 other anti-inflammatories before the insurance company will pay for this particular medication. Off-label use of other nonsteroidal anti-inflammatories is common. All have been reported effective for immediate relief of a migraine headache. Antiemetics are frequently used off-label for migraine, both for the treatment of nausea, but the older antiemetics such as promethazine, metoclopramide, and prochlorperazine have been shown to be effective for more than just the nausea, and when combined with diphenhydramine may be a very effective rescue medication for patients, allowing them to avoid trips to the emergency room. For migraine prevention, there are several FDA-indicated treatments. Topiramate, sold as the brand names Topamax and Trokendi, can be very effective for migraine prevention. Typically, you need to start at a low dose of 25 milligrams and go up very slowly, which seems to decrease some of the side effects. Common side effects with topiramate include paresthesias or numbness and tingling in the hands and feet, weight loss, which occurs in about 20% of patients, and cognitive side effects, which occur in about 10% of patients. Propranolol is FDA approved for migraine prevention. Typically, this is started at doses of 40 to 60 milligrams a day and gradually increased based on patients' tolerance and the occurrence of bradycardia. Propranolol, while it's specifically indicated for the treatment of migraine headaches, is no more effective than other beta blockers for migraine prevention and has similar side effects to other beta blockers. Specifically, if your patient has a history of asthma or ongoing active asthma, beta blockers would be contraindicated. Depakote, or the generic divalproex sodium, is FDA approved for the prevention of migraine headaches. It typically has fewer cognitive side effects than topiramate, but causes weight gain in 20% or more of the patients who take it, and in addition has requirements for monitoring liver function tests and white blood cell counts that make it more problematic to use. In addition, Depakote, as well as Topamax, can be teratogenic and so should be avoided in women that are contemplating pregnancy. There are a number of medications that are used for off-label treatment of migraine headaches. Amitriptyline and other tricyclic antidepressants are often used. They can cause weight gain and a dry mouth. Verapamil is occasionally used for headache prevention, although the evidence supporting this is not as good as other medications. There is limited clinical trial support for the use of gabapentin in adults for the prevention of migraine headaches. There are no published reports of pregabalin's effectiveness for prevention of migraine headaches in adults, but there is a single trial in children showing that it's more effective than placebo for migraine prevention. Duloxetine, sold as the brand name Cymbalta, has had no published clinical trials showing its effectiveness in randomized trials, but there are a number of open-label case series suggesting that it may be effective. Botox was FDA approved for migraine prevention in 2011 and is specifically indicated for the treatment of chronic daily migraine. Chronic daily migraine is defined as having more than 14 headache days a month. Botox is administered in 31 injection sites around the head and neck once every 12 weeks. Typically, patients have to have failed at least 2 standard prevention medications before we proceed to Botox. However, this has relatively few side effects, other than an occasional occurrence of ptosis caused by the Botox. There are new medications for migraine prevention that were approved within the last 2 years. Aimovig was approved in 2018. This is a monoclonal antibody that blocks the CGRP receptor. It's associated with a 2% chance of constipation, and in approximately 15% of patients have an injection site reaction that's defined as either redness, swelling, or pain at the injection site. This is given as a once-a-month subcutaneous injection at home, and it's supplied in an auto-injector for patients to use at home. Aimovig has no specific disease-related contraindications and has specifically been evaluated in patients with active coronary artery disease and is felt to be safe for those patients. Ajovy was FDA approved in mid-2018. This is a small antibody that binds CGRP itself, depleting the amount of CGRP in circulation. It comes in both a preloaded small syringe as well as an auto-injector and has a similar side effect profile to the other products in this category. The incidence of constipation with Ajovy is significantly lower than that of Aimovig. Emgality is another antibody-based product that was FDA approved in mid-2018. Emgality binds onto CGRP, depleting it from circulation. It also has a similar rate of injection site reactions to the other medications in this category, but has a significantly lower incidence of constipation compared to Aimovig. Vyepti is the newest category of this medication. This was FDA approved in late February 2020. Vyepti is an antibody product that binds CGRP and depletes it from circulation. It's administered as an intravenous infusion that's given every 90 days for headache prevention. So let's move on and talk a little bit about tension headache treatment. As I mentioned earlier, patients with tension headaches seldom present to our clinic for care. Acute therapy use of medications like nonsteroidal anti-inflammatories, cyclobenzaprine, and tizanidine are reasonable for tension headaches. There are no FDA-approved medications for the prevention of tension headaches, and we often use medications like amitriptyline or other tricyclic antidepressants or gabapentin to decrease tension headache frequency. Botox was specifically studied in tension headaches in the early 2000s and was shown to be no more effective than placebo for the treatment of tension headaches, and therefore did not get FDA approval for this. Cluster headaches are a headache disorder that needs to be treated fairly urgently. There is a high incidence of depression in patients with untreated cluster headaches. Oxygen is one of the easiest treatments for cluster headaches and can be effective for 2/3 or more of patients during a cluster attack, with high flow oxygen resulting in a prompt decrease in their headache pain. Sumatriptan injection or sumatriptan nasal spray can also be very effective in terminating an acute headache attack. In terms of decreasing their attack frequency or stopping their current cluster episode, there is only one FDA-indicated medication for the prevention of cluster headaches, and that is Emgality. This is given as a high dose of 300 milligrams subcutaneously once a month until their cluster headaches stop. We use verapamil frequently as an off-label treatment for the prevention of cluster headaches. This medication is the most commonly used medication for cluster headache disorders, and it is often used at high doses of 240 or 480 milligrams a day. Gabapentin can be effective in some patients for decreasing cluster headache frequency, as can lamotrigine. Depakote has been ineffective in decreasing cluster headache frequently in clinical trials and is not recommended. Trigeminal neuralgia has no FDA-approved medications for the treatment of trigeminal neuralgia. Carbamazepine is considered the first-choice medication for this condition. It often results in a significant reduction in the pain attack and severity, however, can cause hyponatremia as a side effect. Cognitive side effects from carbamazepine are also relatively common. However, the severity of the pain disorder often makes this a reasonable trade-off for improvement in their pain. Carbamazepine levels as well as LFTs and white blood cell counts need to be monitored on a regular basis while taking this. Oxcarbazepine also appears very effective and may be an alternative to patients that don't tolerate carbamazepine. Oxcarbazepine appears to cause a lower incidence of hyponatremia, but also requires monitoring of lab values similar to carbamazepine. Gabapentin and pregabalin are also used occasionally for the treatment of trigeminal neuralgia and can be effective. There are a number of surgical treatments for trigeminal neuralgia, including radiofrequency or glycerol rhizotomies. There is a microvascular decompression, which is a posterior fossa craniotomy that decompresses the vascular structures that are causing the trigeminal neuralgia by compressing the trigeminal nerve. And in addition, there is a stereotactic radiosurgery treatment, commonly called gamma knife, that can be effective in patients that are unable to tolerate other treatments. These are typically treatments that are managed by our neurosurgery colleagues, and if you have a patient with trigeminal neuralgia who is not doing well, you may want to consider referring them to a neurosurgeon with experience in trigeminal neuralgia. For in-office acute therapy, you might consider treating patients with intramuscular ketorolac and promethazine. You can also consider a short course of steroids if the patient doesn't have any specific contraindication to steroid use. This ends our discussion of treatment options for headache disorders, which is the last section of our CME course on headache disorders. Thank you.